Assalamu alaikum. My talk today is about clinical diagnosis between art and science. And this is a diagram of both brain hemispheres. And you can hear that the left hemisphere is the logical, verbal, digital, analytical one. And the right hemisphere is the artistic one. No more dominant and not dominant, but this is the more functionality. And actually, from the history point of view, the first recorded examples of medical diagnosis are found in the writings of Imhotep in ancient Egypt, and this is called the Evidencebased papyrus. And you can find it at that website. Babylonian medical textbook, the diagnostic handbook written by Isabel Khan Ablay, introduced the use of empiricism, logic, and rationality in the diagnosis of an illness or disease. And you can find this photo on the web. Traditional Chinese medicine, as described in the Yellow Emperor's Inner Canon of Huangdi, is specified 4 diagnostic methods: inspection, auscultation, olfaction, interrogation, and palpation. Hippocrates was known to make diagnosis by tasting his patient's urine and smelling their sweat. We can classify the types of diagnosis into a clinical diagnosis, in which the diagnosis made on the basis of medical signs and patient-reported symptoms rather than any diagnostic test. You can make a laboratory diagnosis that is based significantly on laboratory reports or test results rather than the physical examination of the patient. For instance, a proper diagnosis of infectious disease usually requires both an examination of signs and symptoms as well as laboratory characteristics of the pathogen involved. Radiologic diagnosis is based primarily on imaging studies. So a green stick fracture will be diagnosed only on a radiological basis. You can call it the principal diagnosis when a single medical diagnosis that is most relevant to the patient's chief complaint or needing for treatment was done. Many patients have additional diagnoses. Admitting diagnosis, the diagnosis given as the reason why the patient was admitted to the hospital, it may differ from the actual problem or from the discharge diagnoses, which are the diagnoses recorded when the patient is discharged from the hospital. Basics of clinical diagnosis, or how to reach a full diagnosis. We have 2 methods. The funnel way, in which you start broad, collecting many findings, including symptoms and signs. And you can proceed till reaching the very specific final endpoint or diagnosis. Again, another valid way of diagnosis is the tree pattern. You can catch any symptom or sign like any part of this tree, and you can move up, move sides, move down till the full picture of the tree was made. By now, you have your own full diagnosis. Diagnostic value of symptoms and signs, as well as laboratory tests, can be shown in the validity and reliability diagrams. From the left, you can see here that the arrow pointed at very near points every time, but not at the center. Center is needed. So this is reliable, which means when you repeat your performance, you will give the same results. It's valid when you answer the true answer of the question. Here, in the first diagram, arrows striked nearby, so it is reliable, but it's not at the center, it is not valid. In the second diagram, it's scattered, so that they are not near to each other, low validity, but surrounding the sign, the center, so I can call it low reliability and low validity. In the third one, they are haphazard, but not surrounding the center, so they are not valid. And again, they are not near by each other, they are not reliable. In the last figure, arrows strike the center or nearby and very collected in a small zone. This is both reliable and valid. And when you discuss any symptom finding, any sign finding, any laboratory finding, ask your question. What is the reliability of this finding? What is the validity of this finding to make the clinical, the laboratory, the definitive diagnosis? And remember, there is sensitivity and the specificity of each finding. This will help you. When you read, go through, you learn medicine, try every time to know the sensitivity and the specificity of any finding that is linked to a diagnosis. And sensitivity is the ability of discovering the positive in disease. Specificity reflects the ability to reach the negative in health. Remember this code. Sensitivity is BID and the specificity is NIH. Again, you are using the evidences available from the literature and you should know how to use them. And in evidence-based medicine era, we have interaction between three items: the best available clinical evidence, the clinician experience, and the patient's needs, desires, resources, values, and sometimes one of the guidelines may choose a lower level evidence because it is the only one can be applied and it goes with the habits, resources, values of the population. So this is one of the explanations why some guidelines vary between different communities, and this reflects the need for guidelines for your own community, because patient needs, desires, resources, values, experiences of the clinicians vary between community and other. And then analysis of materials or appraising the evidence you are having. You can appraise regarding the study design, and here the study designs are having different levels. The top of the pyramid is systematic reviews and meta-analysis coming from randomized controlled double-blind studies. This does not mean that we don't need cohort studies or case control studies, but the evidence coming from them is low value. Case series and case reports, as well as the expert opinions, will not actually be of great value in making the diagnosis. But if the expert opinion is going with the results of randomized clinical trial, this is another way to judge the power and the strength of this evidence. However, Keep in mind that the best evidence also is the least available. The degree of evidence of the types can be categorized into 1A, which is systematic reviews of randomized clinical trials, and 1B is coming from individual randomized controlled trials. 1C can reflect the all or none studies. 2A usually reflects systematic review of cohort studies. 2B in individual cohort studies. 2C outcomes research and ecological studies. 3A systematic review of case control studies. 3B individual case control study. And 4 case series. And the level 5 reflects the expert opinion. And I want to stress here the meaning of expert. Expert is the scientist who is working in one zone for the most of his life, experiencing the practice of the patients and as well as experiencing the literature as well. So from these, you can go to grades of recommendation. And if you have results of type 1 studies that are consistent, giving the same results or near results, this is grade of recommendation called A. Grade B, consistent level 2 and 3 levels, or extrapolation from level 1 studies if level 1 studies are not consistent or very consistent. C, level 4 studies or extrapolation from level 2 and 3. D, level 5 evidence or inconclusive studies of any level. And what is the meaning of these levels of recommendation? If it is A, its definition is recommendation based on consistent and good quality patient-oriented evidence. What does it mean? It means you should do this unless there is a compelling reason not to. Recommendation B means it's based on inconsistent or limited quality patient-oriented evidence, and you should strongly consider doing this. C, recommendation based on consensus, usual practice, opinion, disease-oriented evidence, and case series or studies of weaker diagnosis, treatment, prevention, or screening, and the evidence that is improves patient outcomes is weaker for this recommendation. And we can classify types of evidence into 2 categories. Patient-oriented evidence, and this deals with outcomes of importance to patients, a change in the morbidity, mortality, hospital stay, quality of life, symptom improvement, and actually this is superior to disease-oriented outcome, which deals with surrogate endpoints as laboratory findings, blood sugar, lipid profile, which is a good evidence, but not to that of clinical outcome. You can assess the results regarding the power and applicability by statistical power, by quality of evidence, by cost and other contexts. Keep in mind that your scientific knowledge is divided into 2 categories: background knowledge and foreground knowledge. And actually, anyone who is naive will start with background knowledge, taking it from textbooks, and this will give you an idea about the disease. However, if you are asking specific questions for a specific case to reach a specific diagnosis or treatment modality, you need the foreground knowledge and the specific knowledge about a disorder. Here, articles, journals, papers will help you. A diagnostic procedure does not necessarily involve elucidation of the etiology of the disease or conditions of interest. That's what caused the disease or condition. Such elucidation can be useful to optimize treatment. Further, specify the prognosis or prevent recurrence of the disease or condition in the future. The need to do a diagnosis, detection of any deviation from what's known to be normal, a complaint expressed by the patient is usually the starting point from the patient's side, asking the physician to diagnose what's happening. Then differential diagnosis will help. The method of differential diagnosis is based on finding as many candidate diseases or conditions as possible that can possibly cause the signs or symptoms, followed by a process of elimination or exclusion, or at least of rendering the entries more or less probable by further medical tests and other processing, until aiming to reach the point where only one candidate disease or condition remains as probable. The final result may also remain a list of possible conditions ranked in order of probability or severity. The resultant diagnostic opinion by this method can be regarded more or less as a diagnosis of exclusion. Even if it does not result in a single probable disease or condition, it can at least rule out any eminently life-threatening conditions. Unless the provider is certain of the condition present, further medical tests such as medical imaging are performed or scheduled in part to confirm or disprove the diagnosis, but also to document the patient's status and keep the patient's medical history up to date. If unexpected findings are made during this process, the initial hypothesis may be ruled out, and the provider must then consider other hypotheses. In a pattern recognition method, the provider uses experience to recognize a pattern of clinical characteristics. It's mainly based on certain symptoms or signs being associated with certain diseases or conditions, not necessarily involving the more cognitive processing involved in differential diagnosis. This may be primary method used in cases where diseases are obvious, or the provider's experience may enable him or her to recognize the condition quickly. Theoretically, a certain pattern of signs or symptoms can be directly associated with a certain therapy, even without a definite decision regarding what is the actual disease. But such a compromise carries a substantial risk of missing a diagnosis which actually has a different therapy. So it may be limited to cases where no diagnosis can be made. What's meant by the diagnostic criteria? The term diagnostic criteria designates the specific combination of signs, symptoms, and test results that the clinician uses to attempt to determine the correct diagnosis. Some examples of diagnostic criteria, also known as clinical case definitions, are Amsterdam criteria for hereditary non-polyposis colorectal cancer, among others. Clinical decision support systems are interactive computer programs designed to assist health professionals with decision-making tasks, a sort of artificial intelligence. And this is an example of algorithmic approach of certain condition. What are the causes that can lead to error in the diagnosis? Either the manifestation of disease are not sufficiently noticeable, and actually it needs a science and art to go through and to see what's not seen, and to smell what cannot be smelled by others, and to feel what is not there. And sometimes it needs the inner feeling of unhealth or something like that. All these are actually artistic more than scientific. For example, myself, I can smell the odor of typhoid. So how can I teach it? I don't know. A disease is omitted from consideration. You started with the differential diagnosis, missing one possibility which will prove to be the one. Too much significance is given to some aspect of the diagnosis. The condition is a rare disease with symptoms suggestive of many other conditions. The condition has a rare presentation. Examples: is it gastroenteritis or food poisoning? Acute vomiting and diarrhea, no fever. Your usual diagnosis is gastroenteritis. Usual outcome is of treatment is favorable. One will say it may be food poisoning. One will argue, no problem, management is the same. Your confusion here will not lead to a problem because you are usually treating findings rather than the diagnosis. For example, if there is dehydration, you are giving the fluids. If there is vomiting, you can consider antibiotics, but actually you don't care if it is viral or something else. Poisoning may affect the youngest. So multiple members in the family affected by a poisoning may be missing. Astrovirus has a very short incubation period of few hours. So gastroenteritis with astrovirus usually mimics food poisoning. So in this condition, you may be puzzled and you cannot reach the definitive diagnosis. Is there a true difference and you should reach the definitive diagnosis in the previous example? Yes. Recovery is rapid in food poisoning, but not in gastroenteritis. It takes 1 to 2 days in food poisoning, but it takes 3 to 8 days in gastroenteritis. And if you are having a bad place that is a cause of this food poisoning, epidemiologic concerns will mean a great difference. Familial Mediterranean fever, other or comorbidities. Recurrent febrile illness, including severe abdominal pain with periodic pattern. The clinical pattern is classic for FMF. Gene mapping, amyloid A or colchicine therapy test, you are between this dilemma. If you did amyloid test and it was normal, it will be normal in between attacks in FMF, and its high level does not mean definite diagnosis of FMF. And gene studies studying the different mutations usually will not be helpful, but if you are having a whole gene sequence, may be of great diagnostic value. Colchicine therapy may be ineffective in some very rare cases of FMF, and again, and as anti-inflammatory, it can help other conditions. Because of these differences, you will be in a dilemma. Then, what can we see as art or science? In taking history and the examination, because they are a list of findings you are asking about, this is science. But because of the personal differences in asking the good questions, in understanding the different languages, the different slants, the different ways of expressing themselves from the patient's side, this is an artistic way of the interviewer. Laboratory workup. Doing the laboratory test itself is both science and art. Reading them is science and art. So you are between. And finally, our diagnosis cannot depend only on the scientific array we know. And if you are lacking some artistic patterns, which can help you to definitely pick up, to definitely reach from a shortcuts, you may not reach your final destination. So final diagnosis may need time to prove. Follow-up is more important than laboratory tests. Do not be definitive except if you are sure. Impressions may be good, but should not replace a bland approach. When you mature, try not to be trapped by the spot diagnosis. Thank you.